Good evening and welcome everyone. For the very first lecture of our annual e-conference, we have Professor Marc Benninga from Netherlands. He will be talking on functional abdominal pain, any new remedies. Professor Marc Benninga is currently head of the Department of Pediatric Gastroenterology and Nutrition at Academic Medical Center at Amsterdam. We all know him for his extensive research work done in field of functional GI disorders in children, and I hereby welcome him to deliver his talk this evening. Professor Marc, please.
Good evening, everybody. Thank you very much for this very kind invitation to speak about functional abdominal pain. Are there any new remedies? In this presentation, I will present evidence data on foods in children with functional abdominal pain, review the current non-pharmacological treatments of functional abdominal pain, present evidence data on cognitive behavioral therapy and short and long-term effect of hypnotherapy, and I will discuss shortly future treatments. As you all know, the Rome 4 criteria exist, and they are listed on this slide. And today we talk about functional abdominal pain disorders, including functional dyspepsia, irritable bowel syndrome, abdominal migraine, and functional abdominal pain not otherwise specified. And this is a very nice review which was published last year and discusses the therapeutic algorithm for IBS, but also for functional abdominal pain in children. It discusses dietary changes, psychosocial dysfunction, and also listed here are the different therapies, including diets, antidiarrheals, bile acid binders, and antispasmodic. And this is a very nice paper published by Neil Schechter, and it discusses the golden half hour we as healthcare professionals have in discussing chronic pediatric pain. We have to elicit parent and child expectations at the outset, discuss the different diagnostic tests and the value of these tests, validate symptoms, and families usually feel dismissed or stigmatized when mental health referral is made for what they perceive as a physical problem. And we need to highlight that it's a positive diagnosis. IBS is an entity, a clinical entity based on symptoms without any other abnormalities, for instance, found in the lab. And we have to stress this to the parents and their patient. We have to provide education about the prevalence of the disorder, about the relapse of the disorder, and the beneficial outcome of most of these clinical entities. We do like to emphasize a multidisciplinary intervention plan, including medical intervention, but if necessary, of course, also psychological intervention and increased physical activity. And we have to stay connected for a long period, for at least 6 weeks. But in my own practice, I tend to follow these children for at least 1 year. And of course, at the end of the day, we offer an optimistic appraisal. What I also do use is this paper from Lynn Walker from the United States, where she used a water load test to investigate parent attention versus distraction in children with pain and healthy children. And she randomized children to using distraction or attention in their interaction with children in pain. And as you already expected, those children who received a lot of attention by the investigators mentioned more pain. And this was true for those children with abdominal pain, but also in the healthy children. In those children who received no instruction, there was less pain. But as you clearly can see from this slide, distraction was the best offer to give to children with pain. However, the outcome was very surprisingly to me, because when the researchers discussed the outcome of this study, all mothers felt distraction was an inappropriate response to pain, because they knew that their children had to be in pain. So this study shows you that you should use distraction and ask the parents, and especially mothers, not to discuss pain during the intervention you choose for. And this is a slide on nutrition, and you don't have to read this slide properly, but if you're interested in nutrition, then please read this paper by Roberto Di Giorgio, where he discusses the influence of carbohydrates, lipids and proteins and food chemicals on abdominal pain. What about dietary interventions for children? This paper we have written and is submitted. This attracted almost 5,000 papers, and 12 papers were selected to be evaluated. 819 children were included in this systematic review, aged 4 to 18 years. And the trials which were included investigated fibers, FODMAP diets, fructose-restricted diet, prebiotics, and serum-derived bovine immunoglobulin and vitamin D supplementations. No studies were found on treatment with additional fluid intake or histamine-free diet. And we concluded that based on the current evidence, the use of fibers can be discussed in daily practice due to their favorable treatment outcomes and lack of side effects. But I will also highlight some other studies which are included in this systematic review, because now many parents asked for a certain this FODMAP diet. It's an acronym for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And it's based on the absorption of lactose and fructose. And as you know, if these sugars enter the colon, they are fermented and give rise to gas and short-chain fatty acids, which lead to abdominal pain, bloating, abdominal distension, and in most cases, diarrhea. And indeed, in 2014, these Australian researchers showed that a typical Australian diet compared to a low FODMAP diet resulted in a lower breath hydrogen test. And this was also seen for typical IBS symptoms like bloating, abdominal pain, and the passage of wind. And as you can clearly see from this slide, these symptoms were less available compared to those children, to those adults with irritable bowel syndrome who used the typical Australian diet. There are only few papers in the pediatric literature. This is a paper from Gumpitasi, who only studied these children for 1 week. And he showed in this study that the FODMAP diet might be helpful in children with functional abdominal pain disorders. However, a very recent study showed that there was no difference between children receiving a low FODMAP diet compared to a normal diet as prepared by the NICE group, as shown here. Both abdominal pain intensity and frequency were not better using the low FODMAP diet compared to the NICE diet. So there are two small studies, one study showing a positive effect and one study showing a negative effect of a low FODMAP diet. We have to keep in mind that the low FODMAP diet is very difficult for both parents as for the patients to keep for a very long period. What about probiotics? Well, there are not many studies around. This study shows that only the Lactobacillus jejii is effective in children with irritable bowel syndrome, whereas children with functional abdominal pain or with functional dyspepsia were not helped with this specific strain. Another recent study using the Lactobacillus reuteri 17938 was effective in children with functional abdominal pain. But again, only very small studies with different outcomes. What about the psychosocial interventions for the treatment of functional abdominal pain disorders? Again, we have written this paper and it's submitted and under review. We were able to retrieve almost 2,500 articles, of which 33 were selected for analysis, including almost 3,000 children aged 4 to 18 years. And different psychosocial interventions like cognitive behavior therapy, yoga, and hypnotherapy and guided imagery were included in the study and compared to another intervention. And what we showed was that there was moderate certainty evidence that cognitive behavior therapy probably leads to higher treatment success, lower pain frequency and intensity than no intervention, and the number needed to treat was 5. And there's low certainty evidence that there may be no difference between cognitive behavior therapy and educational support for pain intensity and frequency. Low certainty evidence of hypnotherapy may lead to higher treatment success compared to no intervention. Again, the number needed to treat was 5. And there's low certainty evidence that yoga may have similar treatment success to no interventions. I will discuss now a little bit more the highlights of the different studies included. This is an important paper by Rona Levy. We included 200 children with abdominal pain, and she gave 3 sessions of intervention of cognitive behavioral treatment, not only targeting the children, but also the parents. And she was able to show that indeed this cognitive behavior therapy was significantly better than children who only received education support. Other studies using cognitive behavior therapy, this study from Sweden used an internet-delivered cognitive behavior therapy program, also showed that this was better than a waiting list. What about hypnotherapy? We have used this kind of therapy for the last 15 years in our center. And it's based on 6 sessions according to the Manchester Protocol and includes general relaxation, including breathing exercises, control of abdominal pain and gut functioning, and ego strengthening suggestions. Keep in mind that the child is always in control. And this was the first study we performed in our center. And in blue, that's me. I was able to treat children with abdominal pain with diets, painkillers, laxatives, proton pump inhibitors. And this was compared to a hypnotherapist who worked at home and was not able to use any other treatment. And as clearly shown from this slide is that the hypnotherapist was significantly better with respect to pain intensity scores, pain frequency scores, and success at the end of the treatment. How did these children do during follow-up? Well, as you can see, after 1 year in the hypnotherapy group, almost 80% of children were still in clinical remission, whereas those children who received standard medical care, including medication and diets, were only improved in 20% of the cases. And this result sustained after 5 years of follow-up. So in short, this study for the first time showed that indeed hypnotherapy is better than standard medical care. And then Miranda van Tilburg in the United States showed that if she used a CD on which the different sessions of hypnotherapy were included, was also better than medical care. And this was for us the reason to perform a large randomized controlled trial comparing children who were treated by an individual hypnotherapist and compared the same exercises which were put on a CD. Almost 300 children were included in this children with a duration of symptoms of almost 3 years. And as you can see from this slide, there was a high number of children who had school absenteeism. And to our surprise, again, this study showed really positive results where there was no significant difference between those children receiving individual hypnotherapy or hypnotherapy as given on a CD, which is of course much cheaper than the individual hypnotherapist. And if you look at the parents reported adequate relief, this was even much better and showing almost 70 to 80% of the children and parents very much satisfied with the result, both from the CD and the individual hypnotherapy. Significant improvement was also found with respect to anxiety, depression, quality of life, and pain relief, but was not based on the therapist and on the difference of irritable bowel syndrome or functional abdominal pain syndromes, both very important for us as healthcare professionals. Indeed, we did a long-term follow-up study in these children as well. And as you can see, and is similar to our former data, shows that after almost 6 years of follow-up, the majority of children still showed a treatment success of almost 70%. Then a little bit about yoga. This study was published last month, and they were able to recruit 121 patients in outpatient clinics and general public. And they did a long intervention of 8 months, and they showed that dance and yoga were favorable over a standard medical care in this study. So dance and yoga are also probably helpful for these kind of children. What about the pharmacological treatment of functional abdominal pain? This study was published and included 2,000 articles, of which 17 were selected, and almost 1,200 children were included in this systematic review. And these trials investigated antispasmodics, antidepressants, antibiotics, antihistaminic, antiemetics, and some other medications. No studies were found on the treatment of abdominal pain with laxatives, antidiarrheals, analgesics, anti-migraines, and serotonergics. And based on the current evidence, it was not possible for us to recommend any specific pharmacological agent for the treatment of pediatric functional abdominal pain disorders. However, agents such as antispasmodics or antidepressants can be discussed in daily practice because of their favorable treatment outcomes and the lack of important side effects. This is the small study about antispasmodics, which showed improvement and no adverse effects were reported. However, as you can see, it was a very small study which lasted only 2 weeks for a very chronic condition. Moreover, there was attrition bias, and as I already said, a small sample size. So indeed, this study has to be done again with a far more larger sample size. What about antidepressants, which are used commonly in the United States? And this study from the United States showed that compared to placebo, there was no significant improvement, significant difference between the placebo and, in this case, amitriptyline. But still, many doctors, both in the United States and also in Europe now, use antidepressants to treat those children who do not respond on other treatments. What about buspirone? It's a 5-HT serotonin receptor and fundus relaxant. And this was done in Iran, and it showed that, again, buspirone was not more effective than placebo in almost 120 children with functional abdominal pain. I have not much experience using buspirone for these kind of children. This is completely new and published in the United States and frequently used in the United States. It's called percutaneous electrical nerve field stimulation, external air to modulate the central pain pathway. And these researchers were able to include 115 children with abdominal pain, functional gastrointestinal disorders, and were able to show that indeed it's very helpful in this population, not only on symptoms of abdominal pain, but also in functional disability. There was a significant improvement compared to those children who received a sham treatment. Lastly, we will discuss fecal transplant because studies have shown that children with IBS have a completely different microbiome compared to healthy children. There was a meta-analysis which showed in some cases beneficial results of fecal transplants, but others showed no difference in those people who were receiving a fecal transplant. However, a recent study in Norway showed that using only one donor was very effective in treating adults with irritable bowel syndrome, as shown on this slide. Those people who received even 60-gram feces compared to 30-gram and placebo were significantly more improved than the other 3 groups. So this study shows that the fecal transplant might be helpful in these children. Of course, it has some side effects as listed in this table, but it improves abdominal symptoms, fatigue, and quality of life. The study concluded that the use of a super donor with normal dysbiosis index is necessary for successful fecal transplant. However, we have to keep in mind that the placebo response in children with these disorders is very high. And what to do, and if we don't do anything, so we don't use medication, we don't use a diet or placebo, then this study from Italy shows that if you are having empathy for parents and patients, that there's a spontaneous resolution of children with these disorders over 2 years in a high number of patients. So in conclusion, successful management of patients with functional pain disorders is high if you have a trusting, positive, and patient-physician relationship. I showed you that fibers and probiotics only play a minor role in these disorders. The role of FODMAPs should be established in future larger trials, and cognitive behavior therapy and hypnotherapy have shown to be effective treatments in these children. Neurostimulation is new and could be helpful as well, and we need to learn from the device used in the United States. Acupuncture, osteopathy, I don't know. Fecal transplant, there are no data in children, so we have to wait for that. And of course, we can use a placebo. Thank you very much for your attention.
Thank you, Prof. Thank you so much for sharing your experience. I know it was such a vast topic, and to cover it in 20 minutes is a big task. Thank you so much for giving your time to us.